We start first with the week's top stories from Physicians First Watch, read by its editor, Amy Herman. And then we go on to a discussion of the properties of tranexamic acid in lowering mortality after intracranial hemorrhage. This from the CRASH-3 trial. Here's the news.
Hi, everyone. Our first story. A large study finds that testosterone therapy is associated with roughly double the risk for venous thromboembolism in men. The researchers say caution should be used when prescribing this treatment. Just one thing to note. The study was based on prescriptions for testosterone in insurance databases. Next up, in a randomized trial, naloxone injections were better than a nasal spray for treating opioid overdose. The trial was conducted among some 200 adults who experienced overdoses at a supervised injection drug facility in Australia. The next finding might come as no surprise to many of you. In a study, physicians who ranked their electronic health records as difficult to use were more likely to report symptoms of burnout. Elsewhere, the American College of Cardiology and the American Heart Association together published 22 new performance and quality measures aimed at improving hypertension management in adults. Each measure comes with corresponding clinical recommendations. They're worth a look. And finally, a randomized trial finds that vitamin D and omega-3 supplements don't seem to preserve kidney function in patients with type 2 diabetes. Editorialists conclude that the supplements have no role in the primary prevention of chronic kidney disease in such patients. And that's it for this week. Stick around for Joe Elia's latest clinical conversation.
Welcome to Clinical Conversations. This week, Dr. Ali Raja of NEJM Journal Watch Emergency Medicine and the Emergency Medicine Department at Massachusetts General Hospital again joins me as co-host. The CRASH-3 trial, recently reported on in The Lancet, builds on the earlier results of CRASH-2, which showed a mortality benefit for the use of tranexamic acid, or TXA, in trauma patients at risk of hemorrhage. However, CRASH-2 did not focus solely on patients with traumatic brain injury. The newly released CRASH-3 did, specifically enrolling nearly 13,000 patients with traumatic brain injury without major extracranial bleeding. It was carried out at 175 hospitals in 29 countries in a double-blind, randomized controlled trial. However, the results were mixed. While there was no overall reduction in mortality, a pre-planned subgroup analysis showed significant benefit in patients with less severe injury, while tranexamic acid did not have an impact on patients with more severe injury. We have with us the co-chair of CRASH-3's writing committee, Professor Ian Roberts, as our guest. He is professor of epidemiology and public health at the London School of Hygiene and Tropical Medicine and co-directs the clinical trials unit there.
Welcome, Professor Roberts. From a rigorous statistical standpoint, your primary endpoint of overall mortality was actually negative. However, your conclusion really emphasizes that patients with isolated TBI should be treated with TXA as soon as possible. So how do you reconcile the statistics and your conclusion?
Well, I think what you've just done there is probably one of the most hideous abuses of medical statistics. You've divided information into being positive or negative on the basis of an arbitrary cut point.
I love it.
P-value less than or greater than 0.05. Now,
Indeed.
where does that come from? Where does that value come from? What's the difference between 0.049 and 0.051? They're exactly the same. In this particular case, the p-value was 0.0. I think for the p-value for the overall mortality result was 0.053. So first of all, to dichotomize results on the basis of this arbitrary p-value is a nonsense. And in fact, recently, a whole load of statisticians got together and wrote an article in Nature saying that this is one of the one of the awful things that we do and that we mustn't do. And the second thing is I don't even think, now the p-value, behind every p-value there's a null hypothesis. And the null hypothesis is this, that the treatment has absolutely no effect. Now, I don't think that's the reference. I don't think that should be our point of reference, no effect. Because before we did CRASH 3, we did a big trial called CRASH 2. And that randomized 20,000 bleeding trauma patients to get tranexamic acid or placebo. And we got a highly statistically significant reduction in death due to bleeding and all-cause mortality. In a way, I think we should see the CRASH 3 trial as kind of filling in a subgroup in the CRASH 2 trial. We know it works in patients with extracranial injury. It reduces them bleeding to death, mainly on the day of the injury, actually. Most people, exsanguinate on the day of injury. And actually, the effect of tranexamic acid on death on the day of the injury is exactly the same in CRASH 3 as it was in CRASH 2. So the results of the CRASH 2 and the CRASH 3 trial are exactly the same. And so, I don't think the null hypothesis is the right point of comparison, really. This is kind of a subgroup analysis where we say, well, look, is the result of the CRASH 3 trial significantly different from the CRASH 2 trial? And the answer is absolutely not. And so we should say, well, look, why would it make any difference whether you're bleeding inside your head or bleeding inside your abdomen? So I think for those two reasons, that the p-value and the p-value not being dichotomizing p-values being the wrong thing to do, and the null hypothesis being irrelevant anyway, I feel I personally have got no doubt that tranexamic acid is neuroprotective.
We've been chastised for citing p-values.
Well, you wanted something conversational.
Yeah, that's true.
I think that's one of the better answers that I've ever heard about the use and utility or lack thereof of p-values. So well done. Thank you.
All right. So let me ask you a question now. And I ask it hesitantly. You started off with close to 13,000 patients, but roughly 1/4 were excluded. So your analysis sample for that is for people with Glasgow coma scores of 12 and above, I believe, and with pupils that were not fixed and dilated. It was closer to 9,000, which is still a very large sample.
No. The main reason that the 12,000 came down to 9,000 is initially, when we started the trial, we had an 8-hour inclusion window. And,
yes.
And then we realized, and then as, the trial was recruiting for 7 years, but as information accumulated, you think, actually, no, look, late treatment is very unlikely to improve outcome because intracranial hemorrhage occurs really early.
Yes.
And so that we changed the protocol to restrict recruitment within the first 3 hours, and we changed the primary endpoint to patients who are recruited within 3 hours, and all of that was done completely blind to the results.
All right, so patients randomized within 3 hours numbered closer to 9,000.
That's right.
Okay, thank you. So your analysis plans were not thrown off by this because you said, as I will repeat, you said that you did this completely blind to the interim results.
Completely blind to any results, yeah.
We've discussed the benefits of TXA. One of its potential risks has always been thrombotic complications. That was looked at in CRASH 2. But for our listeners who haven't had a chance to read through CRASH 3 just yet, can you walk us through your results in terms of safety and adverse events?
Yeah, I think the adverse event that people always worry about when you give a drug like tranexamic acid. So tranexamic acid reduces bleeding. And it reduces bleeding by, reducing blood clot breakdown, the process of fibrinolysis. Now, whenever you give a drug that reduces bleeding, there's always, pathophysiologically, you worry about the risk that it'll increase the risk of unwanted clotting. So heart attacks, strokes, deep vein thrombosis, pulmonary embolism. So we've always been very alert to the fact that, well, look, if we're going to reduce bleeding, we must make sure we don't increase the risk of, thrombotic side effects. And so far we've been pleasantly surprised. We haven't seen any increase in vascular occlusive events, in thrombotic events, in the 20,000 patients in the CRASH trial, the 13,000 patients in the CRASH 2 trial, the 13,000 patients in CRASH 3, or the 20,000 patients we randomized in a big trial called the Woman trial of tranexamic acid in postpartum hemorrhage. So some people say, well, come on, that doesn't make pathophysiological sense. It must do. Well, my feeling is this, that bleeding, if you have bad bleeding, you are increased risk of vascular occlusive events. So if you have bad bleeding today, you're at risk of thrombosis tomorrow. Because first you're sick, you're lying in bed, and all of that is, that increases your risk of thrombotic events. And so if you can stop bad bleeding, you actually, strangely enough, you reduce the risk of hemorrhage and you reduce the risk of vascular occlusive events. That's only a theory, but the data are the data, and the data show that there's no increased risk of vascular occlusive events. The other adverse effect that I think is definitely a potential is the risk of seizures, because in cardiac surgery, where patients get very high doses of tranexamic acid, sometimes up to 10 times higher than we give here, you get an increased risk of seizures. At the dose we use in trauma, we don't see any increased risk of seizures. So it's reasonably good news that, tranexamic acid seems to be safe in patients with head injury and reduces the risk of head injury death.
I watched your explanation on YouTube to, I think it was the Malaysian participants in the trial. And you never mentioned something that I was looking for, which was a number needed to treat. Did you calculate a number needed to treat to prevent one head injury related death?
Yeah. The reason I don't calculate number needed to treat, because I don't think it's not a generalizable measure.
Uh-huh.
So the measure that you can take from a clinical trial and apply it anywhere is the relative risk reduction.
Mm.
So say, for example, tranexamic acid reduces the risk of bleeding to death by a third. That 1/3 reduction of risk seems to apply whether you're at very high risk of bleeding to death or very low risk. So if your risk of bleeding to death without tranexamic acid, if you're a really bad trauma case and you've got a 30% risk of exsanguination, tranexamic acid reduces that to 20%. If you're more mildly injured, you've got a 0.3% risk of dying from bleeding, tranexamic acid reduces that to 0.2. Now, it's the same relative risk reduction, and that seems to be constant across the risk range. But the absolute risk, the absolute benefit of treatment varies widely.
Okay.
And so because of that, the number needed to treat varies widely. So really, the number needed to treat only applies to the particular patient you've got in front of you. You should say, well, look, what's this patient's risk of death? What's the relative risk reduction? And then you work out how many patients like this would I need to treat to avoid one death? Because the baseline level of risk in the trial is just a sort of accident of the risk of the case mix in the trial. I mean, when somebody did it, I think they got it a number around between 60 and 70.
Okay.
So, of course you can do it, and you can do it for the trial data, but that number of somewhere between 60 and 70 isn't very generalizable, because it depends on what kind of patients you treat.
All right. Thank you.
No, that's true. You've raised a good point, and given the fact that these patients came from 29 different countries with 29 different health systems and 29 different populations, it is really hard to generalize one number, in addition to the fact that they obviously had very varying severity of injury on top of all that. It's a matrix that I don't even want. It's a rabbit hole that I don't even want to go down. Let me ask you though. So to me, it seems as though I should be using TXA for all my patients with minor traumatic brain injury, especially those with a GCS greater than 8 and reactive pupils. The mortality is clearly improved. However, I'm a little unsure yet what effect TXA has on hematoma expansion. I've heard rumors that you might have some plans to study this. Is that true?
Well, we did a small sub-study, but it's actually very difficult. I tell you, it's much harder to do than you realize, because first of all, you've got a very tricky missing data problem when you do this thing, because ideally you'd want to get a scan on everybody. The big idea with randomized trials, you randomize people to get the treatment or not, and then you collect outcomes on everybody, and then you find out the effect of the treatment. It's very difficult to do that with scans, because you can't get a scan on everybody, because two things muddle the data. One is the fact that patients die, and you don't scan dead patients. And two, that neurosurgeons intervene. And so neurosurgery has a big, like you could have bleeds that are taken out. So volumes go down. And so the intervention of death and neurosurgery makes a lot of methodological problems, puts a lot of methodological problems in the way of finding out what the effect of tranexamic acid is on intracranial hemorrhage expansion. But we've got some data, and we'll try and make the best that we can of it, and it'll be published in the future. But what we realize is that this missing data problem is a particularly devious one.
I wanted to ask, what's the wider community said about your results over the past few weeks? Have you had any criticisms beyond the p-value?
No, I think because these are large collaborative trials, what we did is we presented the results to the trial collaborators in all of the, well, not all of the participating countries, but the key participating countries. So, for example, the UK, Pakistan, and Malaysia. We fed back the results to the collaborators, and most of them there was no doubt. Look, it's safe, it works. It's in most of their guidelines for trauma patients with extracranial hemorrhage. And okay, we'll start using it in isolated traumatic brain injury as well. You've got nothing to lose and lots to gain. So I don't think it hasn't been hugely controversial so far.
Okay. And I noticed that, as you, on the YouTube video, as you were explaining the design and the results of the trial, that more and more of the audience were saying, "Oh yeah, this is good stuff." That when you asked them at first, well, is this good or bad? They said, well, we really don't know. But by the end of it, they were saying, yes, I'm going to put it on my breakfast cereal. Just kidding.
I think it's because, all of these things, relative risks, confidence intervals, p-values, they're not, clinicians day to day don't swim in that world really. They're much more thinking about pathophysiological reasoning than this sort of statistical reasoning.
Well, I wanted to ask you one final question, and I had been doing some background reading, and I came across something that you'd written regarding a 10-year-old girl that motivated your interest in this whole question. Could you tell that story to our listeners?
Yeah, a long time ago, I was now I don't see patients. I do clinical trials full time. But when I was a clinical doctor, I think this happens to all doctors. You get one particular case that sort of sears it, burns onto your memory. And I remember this little girl, this 10-year-old girl who was in a high-speed road crash. Two cars crashed. Her parents were in the front. They were killed immediately. She was in the middle at the back with a lap belt. She sort of submarined underneath the belt. And so she had all of this, she didn't have a head injury. So she was admitted, she was like a doll, she was white, deathly pale, but talking to me, and I was holding her head in my hands, and I said, everything's going to be all right. We're going to take you to theatre, and we're going to, stop the bleeding, and, you repair the hole inside your tummy, and then you're going to be better. And then I gave her an anesthetic to put her to sleep, to take her up to theatre, and then I put her to sleep, took her up to theatre. A bit later, I went up to see how she died on the table. And I just felt, oh my God, it just hit me like it had a strange emotional reaction. I mean, it should, death of a child should have an emotional reaction, but this had a disproportionate one in that, when she was conscious, I said she was going to be all right. Then I took her consciousness away by squirting this drug into her, and then she never woke up. And so I felt like I'd killed her, but my sort of reasoning mind said, don't be silly, she didn't kill her. But then as time went on, and I knew more about evidence-based medicine and what works and what doesn't, I thought, my goodness, I could have killed her, because nearly everything I did that day had never been shown to improve outcome, and a lot of it had been shown to worsen outcome. So, for example, in those days, we gave large volumes of fluids. We gave, you'd sort of put the biggest cannula in you could, and then you'd sort of infuse fluids, things like colloids, dextran, starches, things like that. All of that's gone now. Randomized trials have changed all of that. Yeah. So it's low volume resuscitation with, and you don't use colloids because they worsen bleeding and increase the risk of renal failure. And so I became a complete, you get challenged with your own fallibility. In fact, when junior hospital doctors know little but think they know it all. As you get older, you realize how little you know. And the thing that keeps us safe are randomized trials. Randomized trials protects patients from doctors' ignorance, and that's why I love them. And so that's why I spend all of my time doing them now.
All right. Well, thank you for retelling that story, Professor Roberts. I want to thank you very much for discussing your work with us today.
Well, thanks for the opportunity.
That was our 242nd episode. The whole collection is searchable and available free at podcasts.jwatch.org. Clinical Conversations is a production of the NEJM Group, and we come to you from NEJM Journal Watch. The executive producer is Kristen Kelly. I'm Joe Elia.
And I'm Ali Raja. Thanks for listening.